Hello and welcome to the narration for Chapter 40, Alterations of Musculoskeletal Function in Children. A lot of these are very similar to what we see in adults, so this narration should go fairly quickly. We're going to start by talking about some congenital deformities. Clubfoot, also known as congenital equinovarus, this is where the forefoot is adducted and supinated. Okay, so remember your terms from fundamentals and health assessment. So adducted, meaning it is added into the body, so turned into the body, and supinated, meaning pointing downward. Okay, we have a couple of different kinds. You don't need to know those, but just understand what happens to the foot. And we actually cast the children, and so you can see here in this picture down here. This is actually how we treat it. So this is the picture of the child when they were born, and then we cast them, and that keeps the foot in this position. And remember that children's bones are much more flexible and malleable than ours are, and so when we cast them like that, they will form in that direction. And then they very frequently will take the casts off, and sometimes they'll do surgical repairs. It depends on how bad it is. Okay, sometimes they'll take the cast off and manipulate the bone a little bit more and then put a new cast on. Developmental dysplasia of the hip, DDH, this is actually really common. It is an abnormality of the hips. Risk factors for this include being female, having oligohydramnios, which I will spell that for you, OLIGOHYDRAMNIOS. Sorry. That is a lack of amniotic fluid. So not a complete lack, I'm sorry, but a much diminished amount of amniotic fluid for the mother. And then also a family history of this will be a risk factor. And then finally, babies who are breech. The treatment for this is actually what we call a Pavlik harness. This is your Pavlik harness. So you can see here that this particular position, it's actually not uncomfortable for the babies. And this is why some of the front-facing carriers and even back-facing carriers put the baby in this position. You'll probably have seen people carrying their babies in this position, and it's not necessarily that those babies had the DDH, but it doesn't hurt them to have their hips, bent up like that. So, sorry about that. Go back to where I was. Okay, sorry. The way we see it, the manifestations, is that they will have asymmetry of the skin folds at the groin crease. So when you're in your health assessment class, you will have noticed that one of the things you were to assess was skin folds. Skin folds you have at every joint. Okay, you have skin folds at every joint. We're not talking about skin folds from fat layers, okay? We're talking about skin folds where the joint bends. So everybody has skin folds at their hips, at their knees, under their arms, and their elbows. You get the gist. And so one of the things that we will see is that they will be asymmetrical, okay? There are a couple of signs that we can test for. Ortolani's, Bartow's, Galeazzi signs. One of the basically what they do is that they take the baby and a newborn, and they move their legs kind of in a bicycle motion, okay, and they listen for it to pop, because what literally happens is that the hip bone pops out of joint, okay. So that's one of the reasons for the harness, is because it keeps it in. It keeps it in there. It keeps the joint in the ball of the iliac, your pelvis there, where it belongs. Sometimes it's completely dislocated, sometimes it's just subluxated, and sometimes the acetabulum, that the ball on the hip joint, is actually not grown very well. So, but anyway, like I said, very common. Somebody, and you may have known somebody. And then let's see, clinical management, like I said, the harness, they can do casting of it. surgery. Those are for the people who, when they do the casting or the casting and the surgery, those are going to be people who maybe that hip, the acetabulum, isn't fully developed. All right, osteogenesis imperfecta. This is also known as brittle bone disease. It's a defect in the type 1 collagen production, which is the collagen that is in our bones. Okay, it comes in types 1 through 4. 1 and 4 are mild, 2 and 3 are severe. And this is literally, I mean, these kids walk and they break their bones. Okay, so they actually place rods in some of their long bones. We give them lots of calcium and vitamin D. Biphosphates are meds that we actually use to treat osteoporosis. This is known as OI. Okay, and you will see people, I think I have, yes, here's some pictures of OI. Some of the other manifestations are blue sclera. Okay, so you can see that in the top one. Yours are pop-outs on your eye book. Poor dentition, because again, their teeth are also brittle and malformed. Osteopenia, so low counts of bone cells. They break their legs all the time. They're also at risk for aortic aneurysm, and that is because that type 1 collagen is also what we have in our blood vessels, and so their arteries are not as stable as they would otherwise. They're often very short. This guy here, I can't remember his name, but he's a motivational speaker. And you can see here that his legs have been broken so much that they're essentially just kind of sticks. So he is wheelchair bound. His arms are also malformed. You can see here on his right humerus has probably been broken enough that it's malformed there. His skull is probably okay. Sometimes you'll see misshapen in the skulls. You can tell he has poor dentition just by looking at his smile there. So there's a lot of stuff that you can see in that picture. So I found him. You can, if you Google OI motivational speaker, you'll find him. All right, osteomyelitis. So we talked about this already, okay? And this is osteomyelitis in children is very similar to osteomyelitis in adults. The one thing that can happen is that they can get an abscess in the bone without an open wound necessarily. So where they'll actually get a sometimes it's a bloodstream infection. A lot of times maybe children would have a strep infection or something like that and end up with osteomyelitis afterwards. Some of the manifestations of it, now this is from an injury here. This is probably like a, I don't know, who knows, maybe a cat scratch or something. Clinical manifestations are the same as what we see with adults, okay? We go in, we do surgical debridement. This one, here's another osteomyelitis there. So I have lots of pictures here. Antibiotics 6 weeks, like I said, same symptoms as with adults. Septic arthritis is something that we see in children that we don't necessarily see in adults, and it could be the causative factor for osteomyelitis, or it could come from osteomyelitis. Manifestations for this are pseudoparalysis, what they call pseudoparalysis, meaning that they can't really move their joint very well, and it's because of the disruption in the cartilage, okay? They can't bear weight on it, okay? They will have very, very guarded movement if they move at all. That's that pseudoparalysis. They're also going to have systemic symptoms such as malaise and anorexia. Our staph bacteria are the most common causes of it. Just like with osteomyelitis, with traditional osteomyelitis, this requires long-term antibiotics, surgical debridement usually to go in and carve that out. The thing that's special with this as opposed to a traditional osteomyelitis is that this is all caused by our lysosomes. So the lysosomes that go in to destroy the bacteria actually also destroy our articular cartilage. Okay, so that's this area right here. Okay. Juvenile idiopathic arthritis. So remember I talked about this already, and we talked about how this is the childhood form of rheumatoid arthritis. Basically, it works the exact same way as adult rheumatoid arthritis, okay? Sometimes it will be very limited. So this oligoarthritis, oligo is low. It doesn't mean a lack of, but it means low. So if you're oliguric, it means you have very low urine output. Oligoarthritis means less than 3 joints. So this would be like my aunt. I told everybody about my aunt. She had juvenile rheumatoid arthritis. When it was still called rheumatoid arthritis and not idiopathic arthritis, by the way. But hers was just in some of her hand joints, and so she had this oligoarthritis. Polyarthritis is in 3 or more. Still's disease is a particular form that is very severe, and I think I have a picture. Yeah, this girl has Still's disease. Her large joints are affected, and she has arthritis in. She has rheumatoid arthritis in just about every joint in her body, and so she is wheelchair bound from this because the pain is so severe that she can't actually walk. The other thing with rheumatoid arthritis and juvenile idiopathic arthritis is that they do not have elevated levels of rheumatoid factor. So remember, we talked about this, right? In rheumatoid arthritis, we can detect RF, and that's one of the ways we can distinguish it from osteoarthritis. This doesn't happen in kids, okay? Treatment for this, which is also the treatment for adults, by the way, supportive treatment, what we call supportive care or symptom management with anti-inflammatories. Methotrexate is an immunosuppressant that we give, because remember, these are immune-related diseases, and methotrexate actually is immunosuppressant that will help to reduce the joint involvement. Osteochondroses are what we call avascular diseases of the bone. Anything that decreases blood supply to the bone. The most common thing you're going to see is trauma. Any kind of trauma that decreases the blood supply to the bone. I'm going to leave these on here. I actually took them out of your iBooks because they're not really common enough for you to need to know them for patho, and I don't think that they went. Last time I looked at like the most common diseases tested on the NCLEX, these are no longer included. But this Legg-Calvé-Perthes disease is actually of the hip, and it's interrupted blood supply to the femoral head, okay? And so it actually starts to get necrotic because it gets ischemic. And we'll see that they'll actually start to walk funny. So they just do surgery to fix it. Osgood-Schlatter disease is the other one, and it's in the knee as opposed to in the hip. Scoliosis. Scoliosis is the spine curvature. You guys should know that. You've probably already checked each other for it in the lab by the time you listen to this. Most of the cases, it is idiopathic. We don't really know what causes it. Some people, it runs in their family. Treatment is a brace, and sometimes they'll do surgery with severe cases. With mild cases, sometimes they don't even treat it at all. There's usually a student in some lab in fundamentals. So some of you probably have scoliosis, mild, or were treated for scoliosis. But the position that the girl is in on the slide here, and you've got a larger picture in your iBook, I believe, but the position that this girl is in is actually how we check it. We have you bend forward and curve your spine, and then we're looking, and then you just kind of run your fingers down and you see if there's any lateral curvature. The rotation of the spine is something that it's hard to see other than with an x-ray, but there's also a little bit of a rotation as well. Okay, so muscular dystrophy. Duchenne's muscular dystrophy is the most common muscular dystrophy. There's also Beckett's, okay? This is an X-linked recessive inheritance, which means that it generally affects boys, okay? So remember that if it's, and you probably have gotten to this in genetics so far, but if not, here's a quick genetics lecture over X-linked inheritance. When you have X-linked inheritance, if it's X-linked recessive, boys only have one copy of the X chromosome. Therefore, anything that is on that X chromosome, whether it is dominant or recessive, will be expressed in a boy. Women have, or girls have two X chromosomes. So if it is a recessive gene on your X chromosome, you have to have two copies to show it, which is why we don't typically get Duchenne's muscular dystrophy. Because we would need two copies of that recessive gene. Now, the reason that we don't typically ever get two copies in a girl is because generally men don't live long enough to reproduce, although they are living longer and longer. But a lot of them don't reproduce deliberately because they don't want to pass it on. So, manifestations include slow motor development, progressive weakness, muscle wasting. Children will sit and stand on a delayed rate. Usually, we will see this. We'll see that the little boy doesn't sit or stand as quickly as his peers, but really we don't see all of the manifestations until they're about 3. And at that point, we do see delays in motor development. We also will see that the child will often look, he'll just look clumsy. Maybe he falls a lot, has difficulty climbing stairs, and it's because this dystrophin, which is the protein that maintains our muscles, is actually defective, and so it's replaced with a different type of protein, and so their muscles don't work right anymore. And then I took out the Beckett's. Beckett's is less severe, and it's not often tested over, although you will probably cover it in genetics. Okay, so bone tumors in children. We do have benign and malignant. Okay, osteosarcoma is the most common tumor in childhood. It's often a genetic issue. Okay, clinical manifestations include night pain, swelling, warmth in the affected limb, and then it will sometimes metastasize to the lungs. And if it does, we'll see cough, shortness of breath, and chest pain. So we do surgery to remove it if we can, sometimes radiation to shrink it, and then it may require amputation. We'll also do chemo to shrink it. Ewing sarcoma, this is our most lethal bone tumor. Clinical manifestations of this include pain, obviously. Any kind of bone cancer is going to have pain. And this particular cancer breaks out of the bone and forms masses in the soft tissue. So this pain gets more and more and more severe. It also has general symptoms or systemic symptoms such as fever, malaise, and anorexia for this because it has soft tissue involvement, because it does, and because it metastasizes to almost every organ in the body. Okay, non-accidental trauma. This is child abuse. We are legally mandated to report it. You guys know that. What we'll see are the one thing that we talked about are those. Remember the spiral fractures? Okay, so long bone fractures caused by a twisting force. Remember that anytime you have children come in with a lot of broken bones, we have to look at child abuse, but we also need to rule out osteogenesis imperfecta, so OI, okay? The particular type of fractures that we may see are what they call corner metaphyseal tumor fractures, and this is what happens here, if you can see that. We also look for shaken baby syndrome, which is the head trauma from the back and forth. You'll learn coup and contra coup injuries, and it's when the brain bounces inside the skull. I believe that Professor Gooden will talk about that in health assessment. Okay, so we're almost done here. Teach these people about Patho. And so I'm going to have you pause and try to answer these by yourself. Okay. All right. So, number one, Mrs. Rivera is concerned because her son is 20 months old and he's bow-legged. And she wants his little legs splinted to make them straight. So babies actually are born with bow legs. Remember that that the clubfoot is different from bow legs, from bowed legs. So kids with club feet will typically have bowed legs as well. But if the foot is not supinated and adducted, then it's not going to be it's not clubfoot. Okay, so bow legs are normal until the kid's usually about 2.5 years old, and then at that point they'll do like orthopedic consultation to see if they need to be splinted. All right, number 2, we've got a patient with OI. So we need to teach the staff that OI is a genetic disease. It involves defective collagen synthesis, which causes bones to be extremely brittle, break very easily. Okay, so this patient's going to be, so this little boy, he's 18 months old. So think about what 18-month-old children are doing. They're walking, they're falling. This is standard for them, right? Well, when he walks and he falls, he's going to break bones. So we've got major safety issues with him. All right, number 3, Alex has Osgood-Schlatter disease. He wants to know why part of his tibia died and will it grow back. So remember that this is a lack of blood supply, and so that bone actually dies. Sometimes the bone does actually grow back because remember these are kids, okay, and so their bone is constantly growing, okay. All right, number 4, a PA says that a 6-month-old baby fell off the sofa. Why did you report suspected child abuse when that baby had a fractured tibia and some bruises? And why did the physician order full body x-rays? Okay, so we have a 6-month-old baby. So he's not walking yet. And if he's got a long bone fracture, it is almost all, well, I would say like 75% of the time, caused by child abuse. Tibial fractures are very common. And anytime you suspect child abuse, you have to do x-rays to look for head trauma, okay, and then other fractures, okay, that's why we're going to typically do full body x-rays. All right, number 5, Kylie Norman had impetigo. So impetigo is an infection, and remember that's that skin infection, okay, so thinking back to skin, and got osteomyelitis from it, and now she has septic arthritis. So her nurse asked, why do infants get septic arthritis with osteomyelitis more commonly than older children do? And that's actually because the younger you are, the more blood vessels you have going through the growth plate of your bone, and that makes it easier for the bacteria to reach the joint. In older kids, the blood vessels don't go through the growth plate, they actually end right underneath it. Okay, case studies. So go ahead and pause and answer these to yourself. All right. So number 1, Joanna, she's 2 years old. She comes to urgent care with a transverse fracture of her right tibia. And so remember that she's 2, so she is walking and possibly falling and everything. So that's not, that doesn't scream child abuse in and of itself. Okay, but she's withdrawn. She cries when touched by anybody other than their mother. She's had a previous fracture of the right tibia and of her ribs. Her mother does not recall any accidents that could have produced these injuries. So what are possible causes and what evaluations should be performed? So she could be a victim of child abuse and non-accidental trauma, or she could have osteogenesis imperfecta, and we need to evaluate her for both. Okay, so we're going to need to do full body x-rays to see all of that. We're going to do skull x-rays to see if we have any head injuries. Okay, we're also going to look for symptoms of osteogenesis imperfecta, such as, remember, the blue sclera, the malformed teeth, because 2 years old, they've got teeth. Okay, so we can look at those. Number 2, now we have pain in the anterior tibial area after activity. He's 16 years old. He's a cross-country runner for the high school team, and he's having difficulty running because of the pain. So this is probably that Osgood-Schlatter disease, which is osteochondrosis of the tibia. Okay, so remember this is an ischemic avascular necrosis. Okay, and where the bone has actually been deprived of blood. And the treatment for this is rest. Okay, typically it is like 4 to 8 weeks of rest where they can't run, they can't jump. Okay, and gradual resumption of activity we do after about 6 or 8 weeks. But strenuous activity is more like 4 months later. All right, number 3, you're assigned to care for Mark. He's 12 with Duchenne's muscular dystrophy. He's been admitted to the hospital for recurrent respiratory infection. And what findings would you expect to find during your assessment? Okay, so one of the things that with muscular dystrophy, by age 12, okay, they will likely be wheelchair bound. Okay, muscle weakness in his legs will result in him not being able to walk. He'll also probably have contractures of his knees and hips because no matter how much of the range of motion you do, because of the muscle deformities, it's very unlikely that he has not developed contractures. He's also likely to have scoliosis from the pressure of this pressure of the body weight on the spine. And once scoliosis begins, then it actually interferes with lung capacity, which is probably why he has a respiratory infection. We also they're also generally weak from respiratory weakness. Okay, and they will generally, most of the time, these people die from typically a respiratory infection or some kind of respiratory failure in their 20s. So with him, priorities of care obviously include things like safety. Okay, he'll need antibiotics for his infection. He'll need range of motion. He will need turning very frequently to avoid a pressure ulcer. Okay, those are the kinds of things that we're going to do. Obviously, there's a lot more, and he's going to be a very complicated patient. But these are things that at this point in fundamentals you've learned about. Okay, and I think that is it. Yes, because we already did that section. All right. Feel free to email me with questions, and have a good fall break if you don't have lab.